I'm certainly hopeful that we can do some quality of life studies and some investigations looking at patient-reported outcomes that will really define those elements. But as of yet, we haven't conducted those types of studies, and they're certainly resource intense and have limited funding for that sort of thing. But that's certainly a goal going forward in the future. And I think that would be particularly helpful because ultimately, I think we look at these things like overall survival, time to progression, but patient-reported outcomes are more important. And because for some patients, maybe it is how many more months they have or how many more years they have, but at what expense, at what cost, and how is it impacting them in their day-to-day life? Ultimately, our goal is to help patients the way they define having a better life and a higher quality life, not the way we define it. So I think all of these nuances are so important for us to sort out. Even in our clinical practice guidelines, while we talk about the fact that patients with polymetastatic disease, should be considered, there are nuances that we need to sort out. Some of us are operating in select patients with pleural disease, but we don't have much data in that space. That's something we need to sort out. Some of us have done some pneumonectomies in this space. What is the risk-benefit ratio there? I think those are things we need to establish. It is our sense that there is inadequate evidence to suggest anything other than a parenchymal sparing procedure in this case when patients already have systemic disease, that unless it's safer to do an anatomic resection or it's only feasible to get the main tumor out with an anatomic resection, then we do aim for parenchymal sparing procedures if possible. But it's certainly a space where we need more data in terms of nodal evaluation. At this point, we recognize that there's a prognostic benefit to lymph node removal, but we don't believe that it impacts overall survival in this patient population. However, we definitely need much larger groups to evaluate to answer these questions about nodal disease. What we know more than anything is that these concepts that we have such great bodies of evidence and literature supporting how we should be operating on patients in stage 2 and stage 3 disease, they don't apply in stage 4 disease. The cat's already out of the bag. It's a different disease systemically. And so the assumption that because patients with stage 3 disease benefit from a lobectomy over a lesser operation doesn't necessarily mean that that's true for stage 4 disease. And so those are all the things we're sorting out. I think we also need to reassess the risk of surgery in these patients and the types of operations being performed. We know from our previous research that the technical nuances are harder. They are more challenging operations. They are more frequently done using more invasive approaches. They often are in situations where we see extensive hilar fibrosis, challenges dissecting out the hilar structures. Yet we know this isn't our historical lung cancer cohort. These are patients who are often much younger, much healthier, who have really, really fantastic pulmonary function. And so for us to be able to really reassess what risk means in this group of patients is meaningful. The most common complications they have are not the same as what we used to see in our patient population that had different demographics, different social history, and really had different different risk factors. So sorting out risk-benefit ratio in this group is important. And again, getting back to these quality of life metrics, that's where I would really like to see us get some really high quality, social research done on how we're impacting patients' quality of life, both negatively and positively, by offering surgery in these spaces.